Hey, we're on the air. No bad words.
Fridays are the worst when you go to wake up at 8 and then you're like, it's like 7:40 and I'm trying to get out of the shower. I'm like,
All right. We got kind of a big lecture today.
no.
That's
No big shout. It's like 20 less than last week.
Oh,
I
no.
think it's chapter last semester.
Shoot. Okay. All right. So here we go. First, I just want to remind you that your ATI proctored exam is Thursday, March 24th at 2:10 p.m. in AD 17. And everybody got that? So your practice assessment, your RN maternal newborn practice assessment, I think it's 2013. Number A is the one that I'm going to be looking for you guys to have completed before the proctored exam.
Is that outbound to do?
Yeah.
Okay.
And then what day is it that you're coming on Tuesday?
The 15th.
The 15th, 10 to 10:50. Okay, and then again Thursday. All right, everybody on board with that?
I'm sorry, the practice one we just have to complete before the proctor.
Before the proctor.
Okay.
Yeah. Okay. So let's get busy on this fun stuff. These first slides we're going to be talking about diabetes and gestational diabetes. Okay. So during pregnancy, any glucose intolerance, and then we'll do some testing, will bring about the diagnosis of gestational diabetes. But usually in the early parts of pregnancy, the first trimester, we're not having much of an issue with insulin or glucose. It's the second half of pregnancy that it rears its ugly head. Now here are your risk factors for developing gestational diabetes. Okay, and I think I've told you this before. When you look at these risk factors, I don't want you to memorize these risk factors. I want you to look at these risk factors and understand why this could possibly be a risk for gestational diabetes. Put that together in your brain, okay? And then when you're presented with a patient, you're going to be thinking, hold on. Okay, sorry, I got a window. When you're presented with these patients, you're gonna start thinking, oh, she might have a problem here in the later half of pregnancy. All right, so if a woman is diabetic or gestational diabetic, we are really focusing on tight control of her blood sugars. So fastings, we want them to stay below 95, before meals below 100, and then 2 hours after meals. And in pregnancy, we really hone in on the after meals, okay? Sometimes our protocol in the facility is we don't even check the before blood sugar, but we do focus on that 2 hour postprandial, okay? Now, if a woman does have diabetes, these are her risk factors during her pregnancy, okay? And these are the problems that the baby may encounter during pregnancy if mom is diabetic. Now, some of these, like the congenital anomalies and the degree of perinatal mortality, those are really related to a woman who may be diabetic before pregnancy and she's extremely uncontrolled. So she's a brittle diabetic, she doesn't have controlled blood sugars, and then she gets pregnant. Right off the bat, right after fertilization, this baby is climbing uphill, okay? So babies can have severe congenital anomalies that a lot of times end the pregnancy. She ends up aborting, okay? And fortunately, this is not too common. But the macrosomy and the IUGR, so those are two opposite sides of the spectrum, okay? Of course, you would think that someone who has a problem with glucose management, that they're going to have a beefy baby, okay? So that is, most of the time, we do see that. But IUGR, intrauterine growth restriction, is kind of the opposite, okay? And that is because of the effect that the diabetes has on the placenta, uteroplacental sufficiency, okay? So this is your, IUGR is your uncontrolled diabetics. So there's two philosophies for screening women for diabetes. And there's one put out by the Diabetic Association and one put out by ACOG, which is the OB Association. And it just depends your physician, which one he prefers to do, okay? So if he goes with the Diabetic Association, it's just a one-time screening. Well, before we get to that, I'm sorry. Before we get to that, so if you have a woman coming in who has those risk factors for diabetes, okay, you're not going to wait until 24 weeks to screen her for gestational diabetes. You're going to screen her at the initial visit you see her, okay? And you're going to do an A1C and a fasting. And if the A1C is greater than 6.5 or her fasting is greater than 126, she is automatically just diagnosed with diabetes. No gestational, just diabetes. Okay, and she's going to be managed from that point on. Okay? So, now we have the two different philosophies of screening. So if we're with the American Diabetes Association, they do a 75-gram drink, and she drinks it, and then 2 hours later we do her blood glucose. So if her fasting is, before she takes the cola, is greater than 92, or at 1 hour and 2 hours, if she exceeds those values, then she's diagnosed with gestational diabetes. Okay? That's the Diabetic Association protocol.
But it has to happen at 24.
What's that?
It can't happen as soon as possible.
No. So this screening is done, somewhere around 24 to 28 weeks. But this is on a woman who doesn't have those high risk factors for diabetes. Okay? So if she did have those risk factors, you would have already diagnosed her with overt diabetes and are managing her, and she's not going to do this again. She won't be doing this again. Okay, this is your person who had no risks prenatally, and now we're at 24 weeks, and now we're going to screen, because that's when gestational diabetes starts developing. Okay? So the other one, ACOG, the OB Association, they do a two-step approach. So the first is the 50-gram cola, okay? And they test her at 1 hour. And if she exceeds 130 on her blood sugars, then she does the second step, which is the 3-hour 100-gram cola drink. And so, again, if she's over those parameters, then she's diagnosed with gestational diabetes. Okay? Now, if they are diagnosed with gestational diabetes, we're going to see if we can manage them with diet and exercise. Okay? But if we can't, we may need to use insulin. Insulin does not cross the placenta, right? We know that because even in when we're talking about baby being born, we're talking about baby is getting all the blood sugar from mom, and baby doesn't get mom's insulin. Okay. Same thing if we give insulin, baby doesn't get that, but baby's getting those sugars. Okay. So we could use a sub-Q injection on some sort of schedule, or this person, especially if they're diabetic to begin with before pregnancy, they may even have an insulin pump. Okay? So typically, if they're going to be on insulin, they may use this 4-dose regimen, okay, where they get their insulin before each meal and then an insulin at bedtime. Now your book says, I forgot to scratch this out, no oral hypoglycemics during pregnancy. That's no longer the case. Glybride has been shown to be a very effective oral glycemic medication, and it does not cross the placenta. Okay, babies making the insulin themselves, they don't have a problem with insulin, so they're covering all that glucose load. Okay, if we give something to baby that's going to cross the placenta, then baby's going to have a double dose, basically, of insulin. So baby in utero is going to start having hypoglycemia problems. So they just started using Glybride. So I'm trying to think if I've had patients on orals, and I just don't remember having patients on orals. They're usually on insulin. I keep getting this window popping up, and it's not popping up on you. Anyways, so that's what we do for mom. Now, for baby, we want to start surveilling baby, okay, for well-being throughout the pregnancy. We can do this, the alpha-fetal protein, and try to detect for neurotube defects early in the pregnancy. We'll be doing ultrasounds. We really want to know as close as possible gestational age on these babies, because when we start measuring this baby, if this baby is becoming macrosomic, baby's measurements are going to be different. So their measurements, remember when we measure with the tape, the pubic bone to the top of the sinus, that should correspond to the weeks of gestation. But if you've got a diabetic mom with a big baby, your measurements are going to be skewed. Okay? And even when you do ultrasounds and you measure crown rump length and all those kind of things, you're going to get bigger numbers and think that your baby is more older in gestational weeks than it really is. So we really want to be absolutely sure on our gestational age. We'll start doing non-stress tests weekly to monitor fetal well-being till about 32 weeks, and then we'll do them twice a week. Now this isn't on every diabetic, and it's not on every gestational diabetic. It is on those diabetics that we might be seeing some problems, okay? So they don't automatically always get these 2-week assessments, okay? But they may. Now, the contraction stress test we won't do until we're anticipating labor, because we don't need to know if baby's doing okay on the NSTs and the biophysical profiles. We don't really want to know right now how they're going to do in labor. We'll wait and see, okay? And then if we're going to let this woman labor, we might do a contraction stress test. Might. We don't always. Just because she's diabetic that does not mean she buys one of these, okay? But if we have any concern about baby tolerating labor, when it's time, we'll do a contraction stress test.
Wendy, will if it's a large baby, will that show up at that 18-week
No.
ultrasound?
No.
So that should give you a pretty accurate gestational
Right,
age.
right.
But by 28 weeks, you may start seeing the size
Yeah.
differences. Okay.
Right. Okay, so, we let diabetics do labor. We will even do an induction if we start seeing problems, okay? But otherwise, we let these people go to term, okay? And then if baby tells us something that is not good, then yeah, we'll do a C-section. But we don't automatically schedule people for C-sections, even if we feel they have a macrosomic baby. Now, if the physician determines that this woman's pelvis and the size of the baby is not going to relate to a vaginal delivery, then they may opt to do an elective C-section without a trial of labor. Okay, so that's a decision between the physician and the woman. But typically, we will try to let them labor. Okay? Now, once she's in labor, we will do hourly blood glucoses on mom. And if we find that labor is screwing up her blood glucoses, we may end up putting her on an insulin drip, okay? And continue our hourly glucoses, okay? And then, of course, we want to prevent neonatal hypoglycemia after birth, and so baby has their own blood sugar protocol, okay? Now, once they're postpartum, typically most women have no problems with their glucoses anymore. Typically, they don't need to be on orals, and they don't need to be on insulin injections. But we watch these women closely. We still do a lot of blood glucose checks. And I think your book says no oral hyperglycemics with breastfeeding, and that's not the case. They're using glyburide orally with women that are breastfeeding. It does cross the placenta a little bit, but not enough to adversely affect baby, okay? So they weigh the adverse effects with the benefits of breastfeeding, and the benefits totally outweigh the adverse, if there's even any to notice on baby, okay? And then we definitely will recheck this woman at 6 weeks. And then we'll keep reassessing this woman, because if she's gestational diabetic, now she's at risk for type 2 diabetes later in life. And if she gets pregnant again, she's at risk for gestational diabetes again. All right? Any questions about that? What are we talking about here? Okay, anemia. All right. So iron deficiency anemia is probably the most common that we'll see in a pregnant woman. So inadequate intake of iron. So we supplement them. So most every pregnant woman is on prenatal vitamins. And then we can encourage her to eat an iron-rich diet. And so if your woman is anemic, so she's easily tired, more susceptible to infection, and then you add pregnancy on top of that. Okay, so just double whammies on all of these, okay? And then especially at delivery, or if she has any bleeding issues during pregnancy, for an anemic patient, that is compounded, okay? Her ability to tolerate even normal blood losses at delivery can put this woman over the edge. So we really want to make sure we're keeping her supplemented. And so that here's your problems for your baby. So you understand these because you know if mom doesn't have a lot of great circulating blood volume, a lot of great circulating oxygen carrying capacity, there's not a lot of great exchange uteroplacentally, that means baby doesn't get a lot, okay? So you can understand why these could be a problem for baby. Sickle cell anemia, thank goodness, is not so common, but we do have women who have sickle cell anemia. So when they get pregnant, again, it's a double whammy. The pregnancy can even exacerbate her sickle cell crises, okay? So we add additional folic acid to her supplements. And then if she does go into a crisis, she can have those problems, okay? Here's some more problems for mom, okay? So we really want to make sure that we have her sickle cell under control. Congestive heart failure and acute renal failure, that's just major stuff, okay? Very, very possible with sickle cell anemia. So if we have a patient, especially if they're in crisis, we're going to hydrate them, oxygenate them, antibiotics, analgesics, and then take care of baby as needed. So if baby tolerates this until we settle mom down, great, we continue the pregnancy. If baby stops tolerating this, baby needs to come out. And so here's your risks for baby, and these are all, again, pretty self-explanatory why these will be a problem. Okay, folic acid deficiency. It is a big concern because of neural tube defects. So we will supplement these women with more folic acid or the 1 milligram of folate a day, in addition to the prenatals they're already taking. So these are all understandable risk factors. You know, she might need a transfusion, hemorrhage. They can't tolerate a hemorrhage, okay? So even normal blood loss is significant for any anemic patient. So here's a diet that we're going to suggest to help her boost her folic acid, as well as supplementing. And then folic acid is really important, like I said, for preventing neurotube defects in the baby. So, and a lot of times, you know, because if a woman is is anemic before she gets pregnant, and then she finds out she's pregnant after a month or two, okay, baby is already starting to develop. Baby is already starting to develop problems. So pre-pregnancy counseling is so wonderful, but no one ever does that. It would be nice if people showed up and say, hey, I want to get pregnant. I want to have an accidental pregnancy. So I want to be prepared. You know, that doesn't happen, okay? So we really want to get on top of folic acid on pregnant women. So these next few slides have each one of these anemias kind of just blocked out here for you. I put them in here just for, I don't know if you would prefer to study with these or the other slides, but they're in here for you, okay? I'm not going to cover a lot about alcohol and drugs. I am going to show you a picture of a fetal, because I didn't think there was one in the book. Fetal alcohol syndrome on babies, okay? So their appearance is, I mean, you can look at a baby and say, oh, mama had a few parties during pregnancy, because they have these funky folds on their eyes, and there's no bone. Like, this is just flat across their cheek. Okay, they have no ridge there. And this lip thing, so they don't have this little dealy flitch here. I'm sorry, people who I'm recording. But they don't have, I wish I had a pointer. Oh, that wouldn't work either. Oh, you can't see my cursor on there, can you?
The thing below the nose
Yeah, the thing below the nose.
and above the mouth.
Thank you. And then they have flat lips, like they have no lips, okay? And their chin is very underdeveloped, okay? So you look at a baby, even at birth, you can look at a baby and see, this don't look so great. But anyways, these next few slides are the tables with the bad things, the drugs and the alcohol, and how that affects baby, okay? Let me see. That was it. So, so not only does baby have maybe problems going on in utero, so when babies are born, you'll see this or hear this NAS on drug or alcohol babies. That's neonatal abstinence scoring. So when it's an assessment that we do on babies at predetermined times for about 24 to 48 hours that we assess babies for withdrawal. Okay, and this is very devastating. Withdrawal is very devastating to these little guys, okay? And they can be in the NICU on methadone or morphine or something to as a withdrawal medications, and they could be there for weeks. Thank you, Mom. Okay? It's ugly. Anyways. So you can review those. It's a nice chart to help you study. All right, psychiatric things during pregnancy. I didn't put any slides up here. You guys can review that little small section and make sure you just understand everything, and then let me know if you don't. Okay, HIV. So, so you can have women who have HIV be pregnant. And the treatment goals are to minimize transmission, okay, from mom to baby, and then keep mom healthy. So she'll be on this antiretroviral therapy. About 20, by 28 weeks we'll start doing that, and she'll be on that until she delivers, and maybe even afterwards. And then baby may even be on it as well, okay? So we want to prevent transmission. And transmission can occur during the pregnancy, at any time during the pregnancy, and it can be passed through the breast milk. However, the risk during pregnancy are usually associated with delivery or some sort of invasive or traumatic thing, okay? And then the amount that's passed through the breast milk is very small. But if we have women on prophylactic antiretroviral therapy up until they deliver, and then after delivery, if they're breastfeeding, then we can pretty much almost feel safe that we are preventing transmission to baby. Okay? Yes?
Do you see it and maybe you don't have a lot of exposure to HIV with our area.
Yeah.
But, is that something that positive women are doing or insisting upon breastfeeding?
I'm not really sure. If you think about the general population that gets exposed to HIV, the first thing that comes to your mind is some IV drug user or some person who goes around having unprotected sex with everybody in the world. So you think of that person not really caring so much about herself and not really caring so much about her baby. So you're thinking that, yeah, this is not going to be a big, hairy issue, breastfeeding. But there are a lot of people who change their spots. In third world countries where HIV is really prevalent, that's their only option for feeding, is breastfeeding. So, so I don't know. I don't have a lot of experience, and I haven't done a lot of keeping up with this in pregnancy. So I'm not sure how many women, what the statistics are, but you've got some that do want to breastfeed.
Do you know how successful the antiretroviral is in preventing the transmission during breastfeeding?
Well, I can't give you any exact numbers, but it's very low. They feel very safe that the babies will be able to breastfeed and not have a transmission if they're on antivirals. Okay, it's very low. I think I have a slide here that says, yeah, I do. So, so this is how we diagnose baby. We put baby on antiretrovirals. This is not the slide yet. So we want to start it on mom at least by 28 weeks and keep her on it, okay? Still don't have that slide. I do have the slide, I'm sure I do. I'm not familiar with the testing and the results, but there's a slide here that says, if we test mom periodically and that her HIV RNA stuff is less than 1,000 copies or something, then the transmission is very low. But if it goes above that, then it could be a little dicey.
I think it does say that.
Yeah, I think I have a slide, but anyways, we'll see. So if your woman has HIV, just like I said, she might have other sexually transmitted diseases that we need to treat, and she might have hepatitis B, or if not, she's at huge risk if she's running with that kind of crowd, okay? So we just want to check all those things on mom as well. Here's your signs for mom that she has an HIV problem. So during pregnancy, of course, we'll do this visual exam. I think that the OB physician can do this exam. However, if he starts seeing any problems, he'll need to refer her to a specialist. Anyways, we'll start doing non-stress tests on baby about 36 weeks. We'll do ultrasounds to evaluate amniotic fluid levels and baby's growth. If we need to, we'll do biophysical profiles, and definitely avoid invasive procedures because that will increase the risk of transmission. Oh, there it is. Okay? So if her RNA levels are less than 1,000, then we feel pretty comfortable that the risk of transmission is very low. All right, what do we got here? Heart problems. Okay, this is a big section. So if you have a pregnant woman with an underlying heart condition, then that is going to be stressed by the extra demands of pregnancy, which increases cardiac output, increases heart rate, and increases blood volume. So if you have a heart that's not pumping well to begin with because of some sort of problem, then this is going to tax it even more. And here's a whole list of some possible heart problems mom can have. All right. Yeah. So if she's had her heart problem, if it was a defect that she could have repaired, then we put them at the same risk as someone without a heart problem. And then just depending on what her heart problem is, depends on, how bad the pregnancy is going to go. So Eisenmenger syndrome, which I don't think I've ever had a patient with this, but they're at high risk because of this shunting for pulmonary hypertension, and then you add the extra blood volume and cardiac output with pregnancy, and that pulmonary hypertension risk is increased. Okay. Marfan syndrome. I've actually I've had a few patients that have had Marfan's, and I just don't remember any specifics. But anyways, rheumatic heart disease. So these people, again, with all their scarred heart tissue, they can have a problem with their pump as well.
Hey, Wendy, if somebody's coming in, you typically, if they've been getting prenatal care, then CMC or St. Pat's, you'd already have some of their background on some of these issues.
Yeah, unless she's had no prenatal care or even no care or diagnosis of a heart problem. I mean, you could get a woman come in that you have no idea anything about. But if she's had prenatal care, not only is she going to be followed by her obstetrician, he will probably refer her to a perinatologist if there's one in the area, and we do have one in the area, and he will help manage her along with her cardiologist.
Okay. So if she's had no prenatal care, then if it becomes evident, then they're going to bring in some other folks with that labor and delivery.
Right. All right, so mitral valve, a lot of people have mitral valve prolapse. Usually is not a problem in pregnancy. I mean, they may feel some palpitations and stuff throughout pregnancy, but usually they're, they don't cause much of a problem. Now, peripartum cardiomyopathy, very rare heart problem because of the pregnancy. I've seen it once in 20 years, and the person I saw it on was a registered nurse, so if you have RN after your name, expect the worst when things happen. But anyways, she was my best friend, and she almost died. Okay? She had a horrible labor, lasted 3 days, ended up in a C-section, and then everything went well postpartum, and she was sent home. The night she was sent home, she went into congestive heart failure. And thank God she was a nurse, and her husband was a little bit familiar with stuff, and he took her to the ER, and this is what she had. And she almost died. She came in with oxygen saturations in the 60s.
How fast did that happen? I mean, they sent her home.
They sent her home, oh gosh, so this has been 20 years ago. They sent, well, not 20 years, 18 years ago. Anyways, they sent her home, I don't know, mid-afternoon, okay, 2 o'clock. And by, she went to bed, she was feeling bad, feeling weak, tired, went to bed, woke up in the middle of the night, sucking air. And he took her, I think she was in the ER by 2 a.m.
Wow.
Okay? So anyways, you know, it can occur during pregnancy or it can occur after, okay? But hers occurred after pregnancy. So, you know, so they treated the you know, her heart, her oxygen, and all that kind of stuff, and she recovered, okay? But they said don't ever get pregnant again. Don't ever get pregnant again, and she never did.
Just because her heart,
Yeah,
her heart.
because they don't know a lot about this. This is unpredictable. This happens to people who are totally healthy, okay, that have no risk factors. She had none. Okay, she was a healthy woman, and anyways, so she never had any more children. Now her heart's fine now. She had no lasting sequela from this. She was on no medications post event. Totally normal.
Does she go in for like cardio or cardiac checks and stuff?
She did for a while afterwards. I don't know how often or for how long, but I mean, she just recovered. Like just as fast as it came on. She wouldn't have recovered if they wouldn't have. She would have died. She would have died. A little more on Eisenmenger's, or maybe this is just a redundant slide. Anyways, I don't know much about this syndrome. I haven't ever seen it. Marfan's I've seen a couple of times, but so yeah. So our goals are, we want to diagnose any heart disease early in pregnancy, and hopefully they've been diagnosed before she's ever gotten pregnant, okay? And that she has a cardiologist that can manage her. So she'll be seeing her OB, she'll be seeing her cardiologist, the OB will refer her to a perinatologist, okay? And they are going to be constantly watching her heart and how it's dealing with this pregnancy. So yeah, we're going to try to beef up this woman as much as we can with vitamins and iron supplements. Antibiotics, I guess depending on what part of the country and what they decide whether they will do antibiotics on this woman, especially during labor. They don't feel like it's, they don't feel like it's as big of an issue as they had made it out to be in the early days of OB practice, but some may still do it. It's not going to hurt anybody. So depending on her pathology, she may be on some crazy drugs. And there are, in some countries, some parts of this country, there are places that are OB ICUs, okay? There's not very many of them in the country. I don't know how many offhand. I know there's one in Georgia. What's that big hospital in Georgia? Anybody know? Remember? Anyways, they have an OB ICU, and they have patients in here fighting for their life in labor. Of course, they don't let them labor so much. They weigh the pros and cons of labor versus C-section. But if this patient is totally debilitated, they can't. Their heart will not tolerate labor, let alone pushing. Pushing is the big problem. They might be able to tolerate labor, but they will not be able to tolerate pushing. Okay, so they're on these IV drugs that scare the bejesus out of me, just to keep their heart pumping. So she may have an ICU nurse and an OB nurse at her bedside. Anyways, so heart disease is broken up into 4 categories, class 1 and class 2. They have decided that class 1 and class 2, if their heart disease is categorized by class 1 or class 2, then they can tolerate a labor and delivery, probably, a vaginal delivery, okay? But if they're class 3 or class 4, probably not be able to tolerate a delivery, vaginal delivery. So these women are automatically scheduled for cesarean sections. Okay. All right, so nursing care, of course, is depending on the severity of the disease and what that specific heart disorder requires in addition to her labor and postpartum care. And then we have, so nutritional guidelines, activity. These women, we're really going to push these women to not work, lay around all day, let their heart do its thing while she's resting. Okay, so we're gonna check mom out a lot. This is what this slide's saying. Okay. So interpartum care. So if we're allowing this woman to labor, we're going to especially be checking her vital signs, her lung sounds very often, depending on her pathology. We may be doing it every 15 minutes throughout her entire labor, or maybe every hour. Of course, she's going to be on electronic fetal monitoring because we want to make sure that baby is tolerating all this as well. So if mom stops tolerating, then baby will stop tolerating. Okay. So listening to lungs, repositioning, oxygen. She may be on diuretics, maybe on antibiotics, maybe on. Of course, she'll be on analgesics. She might probably even have an epidural. So this is just kind of a redundant slide here. So postpartum, we just want to make sure, just because we deliver a baby doesn't mean that as far as the pregnancy is concerned, a mom is not having any other stressors. It's going to take a while for her to handle getting rid of all that extra blood volume. It just doesn't go away when that cord's clamped. Okay, she still needs to deal with it postpartum. So we still need to consider this woman high risk postpartum and do our frequent assessments.
CMC has the NICU. Do they take high risk pregnancies where the major risk is to the mom versus for the baby?
I think if a woman had a severe cardiac problem where she was on digoxin drips or whatever those nasty drugs are for heart, I think it's a decision that we'll have to make as a unit and with the physician. Can we have an ICU nurse there with the OB nurse through her entire labor? Can we have a cardiologist on standby? Does the physician feel comfortable managing this woman? Even if he has a cardiologist, he is the obstetrician, and so he will be held liable for things going wrong. Okay, so depending on her degree of decompensation during her labor or C-section, if the physicians can all work as a team and they feel comfortable, then yeah, we may manage her at CMC. Okay. But if it's something where we feel is totally unsafe for the patient, we don't have adequate trained people to handle this patient, we'll send her to Seattle.
Seattle, okay. Does the healthcare community consider that kind of a slap, or they just realize you can't be everything to everybody?
Right, no, they don't consider that a slap, okay? We want the best outcomes for patients. It's not just about saving our license. Yeah, we want to save our license, but ultimately we want the best care for the patient, and we know if we can't provide it, she is safer. Okay. So what does that say to the community? Does that say, oh, we can't handle stuff? No, that doesn't. That says we recognize what's going on, and we want the best care for our patients, so we're going to send them to where the best care is. Okay, so that says to the community, we're going to take care of you even if taking care of you means sending you away. Okay, so here's some more things postpartum to take care of mom. Breastfeeding is fine. Okay, all right, moving on. Anybody have any questions about that right now? Okay.
I have a question.
Yeah.
How come in anemia the baby's at risk for infection? nutrition? Is it just because the Willow-2 is just common?
Yeah, so not enough nutrients for baby to build a good immune system. So if mom doesn't have a good immune system because of anemia, then neither does baby, because baby gets immunities from mom. Okay. So just unhealthy nutrition status on a fetus can set baby up for problems. Okay, so your pregnant patient may have some other health problems. Okay. And I'm not going to go through these slides very in-depthly. You can look through these, but you all know asthma and what asthma causes, okay? So you compound that with pregnancy, all right? And here's your fetal problems, and we all realize why babies can be premature and low birth weights if mom's having problems oxygenating because of asthma, okay? Epilepsy, seizure disorder. So unrelated to the seizure disorder that is associated with preeclampsia. Okay, this is just overt epilepsy. So they can be on some medications that may not be so super great for baby. But they try to put them on something that has the least side effects for baby. But the biggest goal to think about here is what is managing mom's seizures. And what is worse for baby to tolerate is a seizure episode, frequent seizure episodes, or a drug that may cross over. And of course, we don't want to give a drug that's going to cause congenital anomalies and stuff, but you have to weigh, okay, you have to weigh your risks. All right, enough of that tangent. All right, hepatitis B. We test all women for hepatitis B. And then we will definitely treat babies. We try to treat all babies after delivery. But parents have to agree to that. They have to consent to that. If they don't consent to that, okay, but baby will get them in their well-child checks, okay? So we do try to routinely vaccinate babies. Usually the pregnancy goes fine. It's after delivery that is the problem. Just like HIV, the risk is now at delivery or invasive type procedures. It says all infants given hepatitis B vaccine, remember parents have to consent for that in the hospital. And then they get hepatitis B immune globulin if their moms are positive, and may get the hepatitis B vaccine as well. I mean, they will be getting the hepatitis B vaccine, okay? All right, so moms with hypothyroid. So usually not a big, huge issue, but because of being pregnant, that can put mom into a thyroid storm, okay? So we want to make sure she's taking her meds and that we're managing her pregnancy well. So we will, do our surveillance on baby, okay? Now, if there's a problem for baby, baby can have a thyroid toxicosis. I don't have a lot of experience with moms with hyperthyroid. We see a lot of moms with hypothyroid. But anyways, if we're treating mom and that crosses the placenta, okay, so baby may end up with the opposite effect, or a hypothyroid, okay? All right. So we'll do our fetal surveillance, just like anything else. So hypothyroid doesn't present a lot of problems if she's being treated, but and most women are on a hypothyroid Synthroid type medicine. So I haven't had any hypothyroid moms that aren't being treated, but it could definitely end the pregnancy if she's untreated. So we'll be testing the babies after birth. Oh, that's all of that. So yeah, there's not a lot of problems if mom's treated during pregnancy. Okay, but if she's not treated, and most moms are, if she's not treated, she may not make it to term. Baby may not make it at all. But then we'll test baby afterwards. Okay, PKU. So this is something you think of when you think about babies. But if babies have PKU, then they grow up as adults and have PKU. Okay, so PKU is an inability, and I'm saying PKU because phenylketonuria is hard for me to say. Anyways, so they have an inability to process that amino acid in protein. Okay. So they're on, people who have PKU are on a special diet, okay? So we test all babies, whether moms have PKU or not. All babies get tested for PKU, all babies, okay? That's that. If you've been in, I don't know if any of you have done this in clinical, but it's that 5-dot blood test.
Oh,
Okay, I don't know if you guys see that. Okay, so maybe we'll try to hit that in clinicals, but it's a blood test we do after 24 hours. So we do it after 24 hours because we want baby to eat, and we need to know if baby can process that. Okay, so we do it at 24 hours. So anyways, so if mom's untreated, if she's not on a special diet, so baby can have these problems, okay? All right, MS. So people who have MS, it's a progressive deteriorating disease. So if they end up pregnant, depending on what stage they are in their disease process, will affect, how the pregnancy goes. So anyways, baby has a little risk, low birth weight. They might have a genetic disposition. So it would be great to do reproductive counseling before pregnancy, but sometimes that's not an option. All right, rheumatoid arthritis. So women who have rheumatoid arthritis, pregnancy can not cure it, well, remission, okay? They don't usually have problems during the pregnancy, it's after pregnancy, so whatever reason that is. Anyways, we continue to treat mom the way we treated her before pregnancy, but the pregnancy may cause worsening pain problems, okay? Just because the hormones in pregnancy cause joint pain, tendon pain, ligament pain, all kinds of stuff. So, so we can still continue their therapies during pregnancy. All right, lupus. So, we continue their therapy for their lupus throughout pregnancy to avoid problems, but they're at risk for problems during their pregnancy as well. So here's their risks for the baby. You know, if they, what's good if you have a perinatologist on your staff is he can do a lot of things in utero that you would not believe to help baby. So, you know, I don't know if they can do anything for baby that has a heart block in utero, but they definitely will need help afterwards. Okay. All right, TB. So, you know, we can test women for TB if they're high risk. We don't usually do it for women who are low risk. They can be on this INZ therapy after pregnancy, and then we want to definitely test for HIV in these women, and also hepatitis B. So, you know, we'll treat the women and then deal with the baby afterwards. So, we can test babies for TB after pregnancy. Usually is not a big significant issue. We don't want direct contact with mom if she's having an active infectious thing going on. So if we can prevent that from happening, then everything will be good between mom and babe. All right, so again, we have slides here with all these disorders if you prefer to study this way. Okay, any questions? All right.
I have a question. Since we're coming back from Warm Springs, have you had much experience or encountered people who were seriously mentally ill coming in for labor and delivery, and how is that managed when their coping skills are?
Yeah, so, you know, we have a lot of gals come in who are bipolar or, you know, have some sort of depressive problem. I've never really had a lot of experience with anybody with like schizophrenia or any kind of like psychotic type breaks during labor. We see those most often. We see an exacerbation or a problem usually most often postpartum. Yeah.
What about cognitively impaired? You know, helping them through, but maybe their coping mechanisms aren't going to be strong, or you know, just trying to help them understand.
Yeah. So, yeah, I mean, we get a lot of people who are mentally delayed, who haven't had an education. We've even gotten 12 and 14-year-old girls that don't even know stuff about stuff, let alone have to deal with labor and delivery. So we usually put the most mommy nurse with them as possible, because they don't understand when we need to do stuff and it's hurting them or making them uncomfortable. They can't rationalize why we need to do that. And they can't accept. They want it to stop. Okay, they don't understand. Like don't do that. Okay, you know, kind of like a child mentality.
They are a child.
Yeah. So I mean, they're hard to handle.
Are you the most mommy nurse?
No.
Just wondering.
I really am not.
Are you that hardcore nurse that's like, just suck it up, lady?
Sometimes I am. I mean, if I, you know, I have a hard time with say 18-year-olds or even 24-year-olds that are going on 18 years old. You know, they've got their crew in there. Everybody's watching videos on YouTube or whatever they're doing, or playing video games, and she's demanding, and you know, she's wigging out with these contractions, and they might not be all that, and she is rude and short and cussing at you, you know, I will try to, you know, this will go a lot better if you're not blah blah blah, you know, and I'll do everything I can to be a nice nurse, but I have a very short fuse, and I eventually will. I have on a couple of occasions got in patients' faces and say, listen, I am here to help you, okay? And if you don't want my help, I will leave, and you will be in here by yourself this entire time, okay? I need you to buck up and act like a big girl, because big girls are the ones that get pregnant. You know, there's a point at which I don't do it anymore. And sometimes that works. Sometimes it doesn't. I've been fired before, and I've been told to get out. I'm more than happy to do that.
Yeah.
See ya.
Thank you very much.
Okay, well, I'll go find mommy nurse. Yeah, I mean, a lot of times, you know, it's just like a bully mentality. They're not bullies, but it's like a bully mentality. If you face them eyeball to eyeball and say, listen, this ain't happening. This is not okay. I'm not going to tolerate this. Okay? You need to be a big girl, and you need to be a big girl right now. And I will be with you every second of the time. I will help you. But I'm not going to tolerate this. I don't have to. And a lot of times when you say that to someone, they're like, oh.
I feel like I'm gonna need somebody like you.
All right. Okay, my favorite stuff. Oh, no. That's not my favorite stuff. So this is just a little bit of review, okay? But what we're talking about is bleeding issues in pregnancy, not so much about the abortion. You guys know abortion, okay? It's any delivery before 20 weeks, period, okay? And that means elective and spontaneous, okay? But anyways, it's a bleeding issue, okay? There's several different kinds of abortions. I don't know if you remember this from last semester. Spontaneous, okay? It occurs whether you like it or not, induced. So you go somewhere and have this done to you. A miscarriage is a spontaneous abortion, but when we talk to our patients, use the term miscarriage, okay? But it is a spontaneous abortion. Here's some reasons why you may have an abortion, a spontaneous abortion, okay? Now, so a threatened abortion is the woman's bleeding, okay, and we feel like it's coming from the placenta, and that the placenta may be trying to separate from the uterus. Forgot my word. We might be able to fix this, okay? If we catch this woman, we put her on bed rest, we give her lots of nutrition, lots of fluids, stress relief, all those kind of things. That's what we can do less than 20 weeks. There's really nothing, we can't give any medicines at 20 weeks, okay, that are really effective in preventing this. But we might be able to save this pregnancy. So if this is going on at 18 weeks and we put her on bed rest, so she might be on bed rest like throughout the pregnancy to keep this pregnancy, okay? Anyways, an imminent or inevitable abortion. We can't stop this, okay? It's going to happen, okay? But we just caught it during its process, okay? It's silly. It's an abortion, okay? But we just caught it during its process, and we're not going to be able to stop it, okay? But she's bleeding, okay? A complete abortion is she has already had the abortion and everything is gone from the pregnancy. Okay, nothing's left behind. Everything's gone. An incomplete abortion is she's passed some of the pregnancy, but not all of it. So maybe she retains the placenta or parts of the placenta, okay? But that's going to increase her bleeding, okay? A missed abortion is the baby has died in utero, but the body has not gone into the process of expelling it, okay? And then, it says if up to 6 weeks. Please, physician, don't wait 6 weeks. Don't do this, okay? Give her some medication so she can pass this pregnancy, Okay, don't wait 6 weeks till she gets infected and goes into DIC. Okay? All right. Anyways, here's just a picture of a threatened, okay? So she's bleeding a little bit. We might be able to help this, okay? And the only thing we can do, bed rest, hydration, nutrition, no stress. No stress. Okay, you're losing your pregnancy. Don't be stressed. You're on bed rest and you've got 5 children running around the house. Don't be stressed. Imminent. So the placenta has pretty much come away from the uterine wall, and she's bleeding, and she's going to lose this pregnancy. Okay? She's in the process of losing this pregnancy. An incomplete, so you see here, she's passed the baby, but she's left the placenta behind, and it's going to keep bleeding. Okay, we need to help her get that out. So a few others. So you're recurrent or habitual, so that's more than 3 consecutive abortions. Okay, we've named this because of people who try to get pregnant. They keep trying, they keep trying, they keep trying, and they have habitual losses. So maybe now we'll step in and help them somehow. Well, they can ask us to step in and help after the first one. It doesn't matter, but so they just decided to name it. So a septic abortion is, so the woman had a missed abortion and didn't pass anything, and now that's been 8 weeks, and now she's septic. She went behind the hotel and had an abortion, and now she's septic. Okay. So anyways. All right. So if you have bleeding during your pregnancy, we're going to do a speculum exam to try to determine, is her cervix dilated, is the bleeding coming from the cervix, or is the bleeding coming from the uterus. We'll do an ultrasound to try to see if we can identify why there's bleeding. So is something going on with the placenta? Wow, that just looked awful light to me. So we'll do an ultrasound, and then a lab test. So we do want to confirm that there is a pregnancy, okay, of course. And then depending on how much mom is bleeding, we'll check an H&H. So again, bed rest, abstinence from coitus. So Sheldon wrote this slide. And of course emotional support, because we're telling her not to be stressed. So if if she's having an abortion, or if she had an incomplete abortion, we'll hospitalize her. We'll put her on fluids. Depending on how much blood loss, we may be doing blood transfusions. But if she's not able to pass that pregnancy, we might have to do a D&C, okay, and help her evacuate that. Now, we will give RH Rogam. Why will we do that? Well, we give that on everybody, for one. Who do we give that to? RH negative moms. Do we test the pregnancy to see if it's RH negative or positive?
Yes.
No.
Why?
Huh?
Because what if the baby was RH negative?
So it's not going to hurt, huh?
Or you just test the parent?
Yeah, we just test the parent and we just give it if she's RH negative. We don't. It won't hurt.
Okay.
Okay. Same thing with so abortions. The same thing if we do if there's some trauma or invasive procedure that we cause bleeding, we might go ahead and give RH or Rogam, okay, to an RH negative mom, because we don't know what kind of interaction happened with that trauma or invasive procedure that might cause mom to start becoming sensitized. Okay. Gosh dang it! I don't know why this keeps. Here, maybe that'll help. Okay. So if we have a missed abortion, it's not expelled in 4 to 6 weeks, then we'll do this. Okay. Other problems with pregnancy is with bleeding. Sorry, ectopic pregnancy, trophoblastic disease, previous, and abruptions. Okay, and we're going to go over those. I think I better hurry. So an ectopic pregnancy is we have a fertilized egg, okay, and it implants somewhere other than the uterus. And most of the time it implants in the fallopian tube, okay? So that can cause a big problem for mom as that pregnancy grows in a fallopian tube or anywhere else it's at. And here's all the possibilities, okay?
Is there a possibility of catching that early, or is there no way to even?
No.
It's so
I mean,
Even if you could catch
I mean,
it.
even if we caught that, I mean, how do we know? So it's fertilized in the tube, okay, period. And then how do we know it's, you know, how long do we give it to get out of the tube? And then once we know it's not out of the tube, we can't do anything to milk it through or push it through, okay? So yeah, we don't catch these until the woman is like, God, I'm having so much pain over here. It's severe and I don't know what the problem is. Okay? So she comes in complaining of these things. Okay? And then we might get a clue that this might be a tubal pregnancy. So we do a menstrual history, we do a pelvic exam, and then we do an ultrasound. Okay? We can see this on ultrasound. All right, and then we'll do our HCG measurements, and then, you know, if we still can't confirm it, we'll do a lab. Okay, but usually we can see this on ultrasound. All right, here's the medication that we can give. Usually not very effective. I think we have to catch it before it really starts growing and implanting well. But usually what we end up doing is a surgical procedure. A laparoscopic salpingostomy. Okay, so a salpingostomy is where they go in and they just take that out of the ovary. Okay, but if they have to do a salpingectomy, they take that out of the tube. Okay, that's the ostomy. They take it out of the tube. If they have to do an ectomy, they have to take the tube. So if that grew enough to rupture and damage, then we usually have to take the tube. Okay? And then here is another instance where we're going to give RhoGAM to an Rh negative mom. Okay? Okay, trophoblastic disease. Okay? So if you remember from last semester when we talked about when that egg is fertilized and that fetus starts to grow, so the first thing that grows is the trophoblastic cells. That's what creates the outside bag of water. Okay, so there's two bags of water. That's what creates the outside bag of water and the placenta. Okay, so something happens in this disease where those trophoblastic cells, they just keep growing and growing and growing. Okay. Anyways. Here is a few different types of gestational trophoblastic disease. Okay, so the hydatiform mole is the most common, and as these cells grow, it just looks like a big old grape cluster, but it's a blood cluster, a cluster of blood grapes, blood-filled grapes. Okay, and there's two types of those. There's a complete and a partial. So a complete is when you take an egg that has no genetic material in it at all, so something goofy happened there, and the sperm didn't know that there was no chromosomes in there, and then so it went and fertilized it. Okay? And that's what a complete hydatiform mole is. Okay? And the partial mole, what happens is we have a normal egg, okay? So a normal egg has 23 chromosomes, correct? And a normal sperm has 23 chromosomes, okay? So what happens in a partial mole is we have a normal egg and two sperm got there and fertilized it simultaneously, okay? So now we have 23 egg chromosomes and 46 sperm chromosomes because we have two sperm, okay? The other thing is that can happen is one sperm fertilized that egg, but something was goofy with that sperm and it didn't go through the appropriate meiotic divisions. And that single sperm has 46 chromosomes. Okay? So anyways, both are not good. And this is not, this won't grow into a fetus at all. Okay? So now we're moving on. So the second type of gestational trophoblastic disease is the invasive mole. And it's pretty similar to the complete mole, but this one is now going to invade the myometrium. Okay, so it's gonna spread its poison in the myometrium, basically. Anyways, and then there's the choriocarcinoma, where it is, the chorion of that fertilized egg is now cancerous. Okay. Here is what that hydatiform mole kind of looks like. So it looks like big blood-filled grape clusters. And that's what bleeds, okay? And she could bleed, or she can pass these grape clusters, depending on if they rupture before she bleeds them out. So they rupture, and the blood comes gooshing out, or just clumps of this come scooshing out.
So it looks like spots, or?
Well, yeah, looks like little.
So, are you gonna have a positive pregnancy test with this?
Yeah.
Okay. How far do you get before you start actually expelling this? Or how far do you get before you know this is what's going on?
So within 4 to 7 days of fertilization. So once that fertilized, and it can even start bleeding in the tube, but once it's fertilized and moves down to the uterus, then you're going to start seeing the bleeding come. Okay.
So it's not like it's something that you like, oh, you're 18 weeks along.
No, yeah.
Surprise.
Yeah. No
ready.
surprise. No surprise. So this grows and continues to fill with blood. And of course, you don't have heart tones. And then, so we look at ultrasound and see this. We see this mole. Okay? Ultrasound. And then we usually have to go in and take that out. Okay? And of course, we give Rogan if she's Rh negative, because we don't know. But choriocarcinoma is a risk for these women, and we have to follow them, okay, for a couple years, I think, afterwards. I can't really remember. Anyways, so depending on how much blood she's lost, we may need to give her a blood transfusion. If they, we'll probably be giving Pitocin afterwards, and then RH, of course, if mom is negative. All right. Hyperemesis, I'm going to run through this. I know I covered this with most of you last semester. The thing I want to say, the thing I want to say about hyperemesis gravidarum is it's different than morning sickness. This is pathological, okay? I'm not just vomiting every morning at 7 a.m., okay? I'm vomiting every day, all day long. I can keep nothing down for days and days and days and days, okay? So, hypovolemia, muscle wasting, electrolyte imbalances. I'm going to start, this is basically an anorexic patient, okay? This is really serious stuff. Hyperemesis gravidarum is serious stuff, okay? I work with pregnant nurses, and they call off because they have morning sickness, and I get really irritated. Really? I know you have morning sickness, but morning sickness is something transient. Okay, you're going to throw up at 7 a.m. and then you're going to be fine the rest of the day. Okay, but hyperemesis gravidarum is not funny stuff. Okay, it's not, oh man, I'm vomiting, now I have a reason to call off work. This is real scary stuff. okay? So we want to control the vomiting, we want to correct the dehydration and electrolyte imbalances, and we want to provide nutrients to this woman, okay? But controlling vomiting is very difficult in hyperemesis gravidarum, okay? We can throw everything, we can throw every antiemetic we want at this woman, and we might not control this vomiting, okay? And if we think we've controlled it, and so now we're going to challenge her with food, it's all gone, okay? So these women will be on electrolyte replacement, and they may even be on TPN. Okay? We have had patients in this community where we've had them on TPN throughout their entire pregnancy. I mean, hopefully this resolves after a while, but sometimes it does not. Okay? So hospitalization, IV fluids, correct electrolyte imbalances. We're going to be throwing at them all these antiemetics, and we may even be putting them on TPN if we can't. You know, we might control the vomiting when she's NPO, but as soon as we challenge her with food, we got it all back again. Okay, so she might have to be on TPN. All right. Okay, hypertension. Love this stuff. Okay, so hypertension and pregnancy. So you have preeclampsia and eclampsia. So basically, eclampsia is the woman has preeclampsia and it's worsened to the point now she's having seizures. That's what eclampsia is. Okay, chronic hypertension. Of course, she may have a hypertensive disorder before pregnancy. Okay, she may have a hypertensive disorder before pregnancy and develop preeclampsia. Okay, or she just has gestational hypertension. Gestational hypertension is hypertension that develops because of the pregnancy without proteinuria. And the reason why I say that is because proteinuria is a criteria for diagnosis of preeclampsia. Okay? She has to have proteinuria to be diagnosed with preeclampsia. If she does not have proteinuria, she has gestational hypertension. All right, so here's our patho for preeclampsia. Okay, the hypertension and the vasospasm that you get with preeclampsia is because, for some reason, pregnancy causes us to lose resistance to angiotensin II. So if we're losing resistance to it, we're letting angiotensin II dominate our world, right? Okay? The other thing that happens is we have a decrease in prostacyclin, which is a vasodilator and a platelet aggregator inhibitor. So we want prostacyclin to work. We want it to keep us dilated, and we want it to keep our platelets from aggregating. But because of preeclampsia, we have a decrease in that hormone. So now we're going to vasoconstrict, and our platelets are going to aggregate. In response, this thromboxane is a vasoconstrictor and a platelet aggregator. And now it's dominating our world. Okay? So the one that's helping us, prostacyclin, that hormone is very decreased. So it's not doing what it needs to be doing. It's not keeping us dilated. And that's allowing thromboxane to come in and constrict us and aggregate our platelets. Okay? So, so what that does is it causes us to have high blood pressure. It causes our blood to be thick and our platelets to aggregate, and it causes problems with uteroplacental insufficiency. So if you have thick blood and you have vasoconstriction going on, you have that going on in the uteroplacental circuit. So baby's getting getting shorted. Okay? Now, so the placenta produces those two hormones. Okay, that's why we think it's a disease of the placenta. And that's why we say the only cure for preeclampsia is delivery. Get rid of that placenta. But even if we get rid of that placenta, we still have those hormones floating around in our system. So even postpartum, for a while, until we get rid of those hormones, we still may have a problem with preeclampsia. That's why we still monitor these people, and or that's why they're still on magnesium postpartum. Okay? And we'll talk about magnesium. Okay, so we have all this vasoconstriction going on, and we have all this viscosity of our blood. Okay? So, of course, that's going to affect our poor kidneys. Okay? So we have decreased renal perfusion and a decreased glomerular filtration rate. All right? So when we hurt our kidneys, then we have a decreased urinary output, and then we start retaining sodium. Okay? And if we retain sodium, what happens to our tissues? We swell. Okay? And all this is also setting us up for more sensitivity to angiotensin II, which is causing us to be hypertensive. Right? Okay. Now, if we're not filtering, then we're not going to be filtering creatinine, BUN, and uric acid. So we're going to have a buildup in our serum, our blood, of those of creatinine, BUN, and uric acid. Now, the other thing that's happening within our glomerular endothelium is those capillary walls in our endotheliums are swelling and stretching, and they're letting big molecules like albumin out and protein out. Okay, so that's where when we do our urine dipsticks and we see our protein. Okay, so again, all this craziness decreases uteroplacental perfusion. Okay, so baby is getting shorted, so we have fetal growth restriction. Okay, and or stress on our baby. Okay. Now for preeclampsia, there's severities of preeclampsia. The first one is mild. Okay, so her blood pressure is greater than 140/90, and she's spilling. Oh crud. Okay, she's spilling. So we do a 24-hour urine. So they pee in a bucket for 24 hours, and then we measure their protein. And so that measurement is greater than 300 milligrams of protein. If we're doing a dipstick, and that's what I forgot to put on this slide, or something happened, we do a dipstick urine in the office or whatever, and it's +1 to +2. So you dip the urine and you look at the bottle and you measure up the colors, and it corresponds to +1 or +2 protein in her urine. Okay, and then they can have a weight gain. Now, weight gain and edema, or edema used to be a criteria for diagnosis of preeclampsia, and it's no longer, because there's other things that cause edema in pregnancy unrelated to preeclampsia. So the two things you must have are the high blood pressure and the proteinuria. Okay, and that's mild preeclampsia. Now, when preeclampsia gets a little worse, oh no. Oh no! Oh wow! Nice, look at that. Okay, there's the slide. Sorry. Okay, so with severe preeclampsia, our blood pressures are now over 160/110. Okay, and we're spilling 5 grams in our 24-hour urine. Okay, or we're +3 to 4 on our urine dipstick. Okay, so those are the criteria for a severe preeclampsia. Now, if you remember the renal involvement, okay, because we have decreased blood flow to our kidneys, we're going to have decreased urine output. So we will see less than 500 cc's in a 24-hour period. Okay, some of us can go 500 cc's at one time, and then do it again 2 hours later, because we're old. Anyways, here's your signs and symptoms of preeclampsia. So when I have a patient come in, especially if she has any blood pressure issues, I ask her, do you have any problems with your vision? I ask her, do you have headaches? I ask her, do you have right upper belly pain? Okay, those are signs of worsening preeclampsia. Those are my assessments. The other things that I'm going to look at is her reflexes and her clonus. So her reflexes, I test for DTR. So I have her leg. You guys know how to assess for DTRs, right? In the knee or the patellar. Okay, so you go like that. So +2 is kind of a normal. +1, +2 briskness. So if I go like that, so mine's probably, that was probably a +1. +2 is a little more better. That's normal reflex. But if I do that and she kicks me in the jaw, that's a brisk hyper-reflexic. That is telling me that her central nervous system is hyperstimulated. It's firing on all 8 cylinders, okay? That tells me that, well, she might have a seizure, okay? And then clonus is you take the foot and you dorsiflex the foot toward the knee. And if she has clonus, clonus is the foot will bounce, okay? So if I dorsiflex her foot and it goes like this, I count how many times it does that. And if it does that one, I say, hey, she has 1 beat of clonus. So that is another indicator that her central nervous system is a little freaked out right now, okay? If she has 2 or 3 beats of clonus, that's more hyper-reflexive, hyperstimulated central nervous system. I have to test someone's DTRs, and when I test DTRs, I will lift their leg up and say, don't help me, I want your leg to be dead weight. And then I will feel for that tendon. And sometimes when I feel for that tendon, she has a reflex with that. And I didn't even do the karate chop. That's way, way, way hyper-reflexive. And I'm just like, oh my God, let's get to this right away. So if she had a seizure, then she is eclamptic now. Okay? And then even if she hasn't had a seizure, another worsening situation with eclampsia or preeclampsia is HELP syndrome. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. So if we get someone in with a mild and or a severe preeclampsia, we will draw blood and we will look at their CBC, we will look at their ALT, AST, which is their liver function, and then in their CBC it'll tell us about their platelets, okay? And we may even do a uric acid test to see if that's elevated. Remember, because we're not excreting that, okay? All right, so eclampsia is seizures, okay? All right. So take these notes. So we will, for an eclamptic patient, we may give, I'm sorry the slides are not there, we may give these women labetalol while they're in the hospital. There is a protocol to give incremented doses of labetalol. I think it starts 20, 40, 60, and 80, or 20, 40, and 80, I don't know. So we can give that IV push. We can give hydralazine IV push to control their blood pressures. And then we will probably most certainly put them on mag sulfate, which is an IV drip, a continuous IV drip. Mag sulfate is used to lower or to increase her seizure threshold. So what we're trying to do is we're trying to push her seizure, her ability to have a seizure, way back. All right? And a side effect of mag sulfate is hypotension. Win-win. Okay? But mag sulfate is a very dangerous drug. It's a black box drug. It requires 2 RNs to hang it and adjust the rates. Because if I program the rate wrong, like for instance, when we start MAG, we give a bolus. Okay? We give it in 15 to 20 minutes. It's a 4 to 6 gram bolus. And to do that in 20 minutes, our rate can be anywhere between, I don't remember now, 200 to 400 cc's an hour. And we want that to run in 15 minutes. So if I plug in 400 cc's, a rate of 400 cc's an hour, and I don't plug in a 400 cc, or I'm sorry, if I don't plug in the correct volume, then one, like if I do 400 cc's an hour and I plug in my volume 400 cc's, how much is going to run in an hour? 400 cc's, but it's not going to be a bolus because I didn't give it in the 20 minutes. Okay, so let's just use 15 minutes because I do better with that in math. So if I have to run it, well, it ends up, so I have to run it at 400 cc's. This was the correct answer. 400 cc's to get it in 15 minutes. So that ends up being, what's that? 100 an hour?
1,600 an hour to give you 400 and 1,500.
Okay, so that's not correct either. So I'm sorry. I have to see the order. I'm sorry. But anyways, the point I'm trying to make is, see how we could have just OD'd this woman on MAG, okay? If we don't get the rate right and the volume right, then we may OD this person on MAG in 15 minutes, and she could stop breathing within 15 minutes. That's how dangerous this drug is, okay? So let me think. So 2 grams is 29 an hour, so 4 grams is 58 an hour. So 58 times 4. Who can do that?
5,800.
58 times 4 is
232.
230? What did you say?
232.
So that would be our rate, and our volume would be 100 cc's or something like that. Okay? So you can see how if I screw things up and I mess up that rate, I can, in 15 minutes, I can OD this woman and she can stop breathing.
Does that happen?
Yes, that has happened. That's why it's a black box, and that's why it requires 2 RNs.
Like it's happening on your shift.
Mm-hmm. Yeah. Huh? She did. She did live. Because we caught it really quick, but still, it's bad. So we do frequent assessments on MAG. One of the assessments we do is we assess her level of consciousness. Okay. So if we're calming down her central nervous system, if we're relaxing her central nervous system, then we're going to make her we're going to make her level of consciousness relax as well. Okay. If we relax her CNS too much, we might relax her respiratory center and cause her to stop breathing. Okay. So, and then of course our DTRs and our clonus are going to start becoming relaxed. So we check those, DTRs and clonus. We check her respiratory status. We check her level of consciousness several times depending on the rate. We may do that every hour or every 4 hours. Okay? So that, huh?
If you have someone on the magnesium sulfate, are you going to be in the room the whole time? No?
No. No, because one, they're on continuous fetal monitoring. They're on continuous pulse ox. I'm going to be in the room frequently, but I don't have to stand in there. Okay? All right. So the section on trauma, I didn't put any slides, but you can read that. Okay? I didn't put any slides on abuse. You can read that little section. Infections. I do have some slides on this, and in the light of time, I'm just going to run through these. These are things that we test prenatally, and depending on those results, we may end up treating mom, or we may end up not treating mom and have to be on constant pregnancy surveillance throughout her pregnancy, or we may be dealing with these issues when baby is born. Okay, so here's this slide. So each one of them I've broke down into the fetal risks, so you can look at those, and the treatment for each one of those things we test for. Okay, here's on rubella, cytomegalovirus, herpes. So I do want to point out for herpes, if the woman comes into labor and she has no active herpes lesions, we can allow her to deliver vaginally. But if she has herpes lesions, she has ordered a C-section. okay? All right, and we do try to treat women, you know, maybe at 36 to 38 weeks, we'll put them on acyclovir to help prevent outbreak, so maybe they can deliver vaginally. GBS, I want to point out, we screen about 36 weeks for GBS. It's a vaginal culture, vaginal rectal culture. Okay, half of us in this room are GBS positive, meaning that we have group B strep as part of our normal flora. It doesn't do anything to us. It doesn't do anything to our sexual partner. Okay, it's just a normal flora of bacteria. Okay, but for baby, it's not normal. It's devastating. Okay, so we test them at 36 weeks, and if they're GBS positive, we know that we will be running antibiotics on mom during labor. It is not to cure mom of GBS. It's not to eradicate her GBS. It is prophylactic treatment for the baby, so baby does not end up becoming infected from GBS. Okay? If we get a woman in that has never had a GBS culture, or maybe she had one and we can't find the results, we treat her because we don't know. If she comes in and delivers and we don't know what her GBS status was, or we know it was positive, but we didn't have time to get antibiotics on board, then we're under increased surveillance of baby. And I think the protocol says that if those babies have not been treated with at least 2 doses of antibiotics, they stay 48 hours in the hospital, period. Okay? So that we can constantly watch them for developing infection. They don't need to be in the NICU, but they can be in a normal newborn
Is
nursery.
that just vaginal delivery then? Or if you have a C-section, do you still treat?
No, we don't treat for C-section, okay? Because the idea is babies are not passing through the birth canal and they're not going to be having transmission of that bacteria if we pull them out C-section. So if you're planning a C-section at 39 weeks, you've got it scheduled in the books. Do you need to have a GBS culture?
Yes.
Why?
Because you're labor before.
You may go into labor before that. It's good to do that. Okay? All right. Okay, so parvovirus, you can read that. And here are those that, oh no. So these are vaginal infections. You can read about these vaginal infections in this nice little chart. And the treatments and the problems with pregnancy, or what they'll do in pregnancy. Okay? So I do want to talk about RH as much as I can. We did discuss this in PN, but let's go over it again. Okay? Really quickly. And if I'm going too quick and you have a question, please stop me, because I'm just gonna fly unless you land me. Okay? So RH positive. RH is so they have the D antigen on their red blood cells. Okay? So they're RH positive. If they don't have that D antigen, they're RH negative. Okay, great. Who cares? But the problem is if an RH person gets exposed to RH positive, then they start creating anti-RH or anti-D antibodies against RH positive. Okay? So, still, who cares? Well, what happens is, if she's created those antibodies and she gets pregnant and her baby is RH positive, she now has antibodies that can run through the placenta and go attack that RHD on that baby. Okay? If that happens, if mom has created antibodies, she has now been sensitized. Okay? So we want to prevent we want to prevent her from being sensitized. Okay? So this kind of explains, I think, what I just said. All right? So her first baby, usually there's no problem with the first baby. Okay? Because when this occurs, when mom gets sensitized or when mom gets exposed, it's usually during an invasive procedure or delivery. Okay? And so if that happens during delivery or an invasive procedure, well, if that happens during delivery and mom gets exposed and she creates the antibodies, well, that baby's out and safe, okay? But if she had an amniocentesis or she had some sort of trauma during pregnancy, and baby was Rh positive, then mom can now become sensitized in that pregnancy and cause problems for that baby. But usually, the first baby is safe. It's the second baby, okay? That if the second baby is Rh positive and mom was sensitized with the first pregnancy, then mom's created antibodies, and now the second pregnancy, if baby is positive, those antibodies are going to come over to baby and attack. Okay? So that's why we give the RhoGAM. That prevents her from developing those antibodies. Okay? Questions?
So if she had RhoGAM her first pregnancy, would she need it her second, or is she?
Yes, you have to keep, we do keep doing that each subsequent pregnancy. Okay? All right. So if we do have sensitization, if mom's antibodies do cross the placenta, this is what happens to poor little baby. All right? Marked jaundice, and the more baby gets jaundice, the more they're going to cause neurological damage, unrepairable neurological damage. Okay? Anyways. All right, so I basically said all this. So if mom is sensitized, then we will do a titer to see how many antibodies she has. If the titer is elevated, we can't really do anything. We just have to kind of watch the pregnancy, we do our fetal surveillances throughout the pregnancy, okay? And then definitely when baby's born, we're going to have to react, okay? If she does get exposed to Rh positive blood, in other words, she didn't get RhoGAM, okay? If she does get exposed, we're going to give this Rh immunoglobulin to help keep her from being from producing antibodies, okay, against the her being exposed, okay. So our interventions for baby. So this is pretty rare anymore these days because we know about RhoGAM and Rh negative now, so we do this in pregnancy. But back in the day, or if something happens and we miss something, we can do an intrauterine blood transfusion. So intrauterine means the baby's in the belly, and we can go in and do a blood transfusion. Okay, pretty awesome, cool. They just did this a couple weeks ago at CMC. Anyways, all right. So we're gonna who?
Is the transfusion because?
This actually wasn't an Rh issue. This was no one knows that this mom is creating all these antibodies. No one knows why she's creating all these crazy antibodies. But the antibodies that she's creating are crossing the placenta and attacking baby. But and she's been having like serial transfusions, intrauterine transfusions. And she's only like 28 weeks, and it'll continue.
So, are those?
Huh? We're hoping not, but we won't know the true effects until baby's born. So baby is going to be at risk for jaundice and all kinds of other things. So, all right. I just put ABO incompatibility in here. This is really not a huge issue, okay? But, I mean, just because it's pretty rare, even if we do have an ABO compatibility to cause much problems, okay? Usually it's kind of self-limiting. But just remember, Group A and Group B fetuses, the effect is, let me say it this way. I should have wrote it this way. If mom is type O, okay, then if baby is A or B, then we have an ABO incompatibility, okay? So we may have a little bit of hemolysis, but not much. It's usually self-limiting. Baby may be a little bit jaundiced. We can take care of that. But usually not a big, hairy deal, okay? Any questions? 1 minute to spare.
I get why the
I wet my
RH
pants, but that's
factor is,
okay.
like, so bad for baby and mom, but why is the ABO like not really significant?
I mean, I don't know, except that it does cause a little bit of hemolysis, but it's usually self-limiting. So in other words, it doesn't cause a terrible, I mean, it is an incompatibility. It does cause a little bit of a hemolysis. There's not enough, so like if an O person got A blood, there would be a huge transfusion reaction, because they're getting large doses. They're getting a whole bucket of blood. So the transmission, or the mixing of mom's O with baby, it's so very minute that it doesn't cause a big of a hemolysis deal that the RH does. I mean, I don't know any better explanation than that. That's not pathophysiology, that's just what happens, okay? It's just not enough to be a big hair deal. Not good enough, but that's the answer. I'm giving you.
It works.
All right.
Push it over, dude.
Slide it over. Get super- and also the table.
I heard my alarm. I might have to call in for a show of support if you do that.
Who's your dog doing this?